You're listening to the Physio Matters podcast in association with Choose Health, and this is session 47. Welcome back to Physio Matters. I'm Jack Chew. First things first then, massive thanks to our last guests, plural, with Connect Health. The last podcast gone down really well. Sometimes when we touch topics like that, where it's not a specific clinical entity and it's something a bit more abstract, sometimes feedback's a bit sluggish coming in, but for this one it really seemed to tickle a few people's fancies, and we got a lot of really interesting information back where people are generally in agreement with the proposals being pushed forward for how we can define and achieve clinical excellence. So thanks again for getting back to us on that. It's really interesting. For patrons, if you haven't already, then have a little look. There's a bit of bonus content on there where we touch some even more edgy topics and controversies, so make sure you gobble that up. A few things to catch you up on. In the last month, we covered the ATOCP conference, which includes some live streaming of things like Justine Thieker talking about the Twilight service for total knee replacements, which is just essential listening. 20 minutes on their Facebook Live, so check that out, still there. As well as a live debate between two shoulder surgeons and two rehabilitation physiotherapists about rotator cuff surgery. Should we, shouldn't we? Made me realise. I mean, I chaired that debate, which was an interesting role for me, just to highlight how much variety I get in my role and my job now, which is really cool. So thanks so much for the ATOCP for inviting us and getting us involved in that, and please do check that out. So you've got, I think, over an hour of debate back and forth. I think a good learning experience as well to do something like that, because I, as a physio, was trying to just play devil's advocate on sides and things like that, and I was so conscious not to suddenly make it a 3-on-1 physios versus surgeons that I reckon I possibly overcompensated. When I've listened to it back, I sort of think, oh, maybe did I balance the time well enough between the two sides of the panel? So do check that out and let me know what you think, and certainly I'd appreciate it if you feel like I unfairly managed the situation, then it certainly wasn't purposeful, and I can always improve on that, because that's something that I haven't done before, is moderate a debate. But certainly we're looking at potentially bringing something like that to life on the Physio Matters show on the main feed. We could do even the same topic or something similar, and especially with regards to surgery, I think it's a really interesting thing. So let us know what you think of that if you get a chance to. Talking of the variety of our roles, we have a really interesting event coming up that we're doing in partnership with Connect Health, who were on the last podcast, which is, you want to be checking out #TheBigRs, because we're doing an event it's invite only, so that we could pretty much put all the kind of names of people that we've bumped into over the journey that we've had with Physio Matters and the events and coverage that we've done, and just trying to find edgy but pragmatic voices that can really try and help us to grapple with some of the most important topics in the profession. It's an event in which we're calling the Big R's, which is reasoning, responsibility and reform. Things that we hold dear and Connect agree, and therefore we're going to put this together and see what comes out of it. It's going to be mainly discussion based, with the 58 top thinkers in a room, a massive diversity of views within that, but all with a key message of trying to come up with some strategies of what we're trying to get to and what we're trying to achieve, which is going to be really interesting. So yeah, keep an eye on the hashtag across this week, as well as then around the event, because we'll start to feed out what that event's trying to achieve, and we'll try and get that information out to you once it's been sensibly curated. We want to make sure that whilst we're usually transparent and we bring you everything, we want to make sure that there's a space in which people can openly and freely express their views, which may well be something that they wouldn't want to make public, because they might want to construct them and think about them and plan them out and have back and forths in which we want to be more readily wrong. So that's well worth keeping an eye out for. That's #TheBigRs. But one of the reasons that I'm all loved up about how wonderful my job is and the roles and responsibilities that we have as a business now is cool, is because our podcast guest that I bring you today actually he was up in the Northwest, and so he came around and we recorded this podcast in my house, which I don't think we've done before. And it was just an absolute pleasure to meet him and discuss these things with him. I think it's such an interesting story, both in terms of the journey and his clinical thinking, his experiences in various different roles, both clinically and operationally, and even in policy making and things like that. So you get such a breadth of insight from Chris in this one, and we could cover a topic that we've sort of touched on before, In other episodes, we had Sally Lamb on the podcast and we discussed the Mint trial and whiplash more generally. We've definitely had circumstances where we've touched on other neck conditions that have kind of cropped up when we've talked about red flags or we've talked about radiculopathy. So it's really nice to have just sort of covered some ground over mechanical neck pain, traumatic, atraumatic assessment, treatment, management. So absolutely brilliant to bring you this. I'm really pleased. I know you're going to love it because he's such a great guy. He's such a great guest, and I look forward to speaking to him again about various topics, and I doubt it's the last time he'll be on the show because it was so wide-reaching and wide-ranging. Pretty much a one-take wonder because this man knows all these things in neck, and he was completely open to me asking him whatever I wanted. So I thank him once again for his time. Know you're going to enjoy this. Make sure you spread it far and wide. Keep an eye on the hashtags that I've mentioned before. Check out the other content and join us on Patreon if you want even more from us, because things are really picking up pace and we've got some exciting announcements for what we're going to do into the new year. So please do get behind us if you like what we're doing, and thanks as ever for all your feedback and comments on social media, on email and beyond. So all right, I'll see you at the other side. Okay, delighted to be here today with Chris Worsfold. I hope I'm saying that right. I keep thinking,
it's Worsfold.
Worsfold.
I get called all sorts.
Not Worsfield, I called you that in my head at least for a long time, so glad we clarified that straight up. To talk all things neck. So always best to start really with an introduction to you for the listeners that don't know of you, and some of your background as well, if you don't mind.
Yeah, so I'm a musculoskeletal clinician, and I work in the southeast of England, in Kent, in Tonbridge. And it's a full-time musculoskeletal caseload, and I'm 30 years qualified this year. And over the years, I've worked in full-time research posts and done postgraduate qualifications in rehabilitation studies and injection and medico-legal sort of areas. And my main focus is neck pain. So about a decade ago, I decided to sort of set up a private niche clinic in neck pain and whiplash injury, which meant sort of putting my hand on my heart and saying, is this a centre of excellence? Is it evidence-based practice? So looking through all the journals and books, etc., and trying to apply that into practice. And then really a course grew out of that, a whiplash and neck pain course grew out of that. So I've taught that for nearly 10 years now as well, and that's recently changed into more of a neck rehabilitation course. And over the years I got involved because of my interest in whiplash and the medico-legal sort of practice I had. I represented the Chartered Society of Physiotherapy in Parliament in 2013 when the government was reforming the whiplash medico-legal system. And I was on Ministry of Justice boards in a small company that the government set up for a short time, for about 18 months as well. But I've left all that work now to return to clinical practice and teaching, sort of what gets me out of bed in the morning. And more recently, I've published in the area of predicting outcome in whiplash and just contributed to 2 chapters in an undergraduate text as well on neck pain.
And how much of your clinical caseload is necks?
Yeah, it's a good question, yeah. So it's a mixed caseload, and it's probably much more than most musculoskeletal sort of private practitioners would see. I get people travelling miles to see me, which presents its own problems because they're often late. But
late and stiff when they get there.
Yes, that's right. Yeah. So I haven't got a percentage, but it'd be more than most.
Yeah. Okay. And is that across? Is your private practice the full-time role? Split role in that. Yeah. No, really interesting. And so I'm interested just to touch on the sort of. Well, I think it'll probably emerge in the interview as to a journey of thinking that we all tend to have in our careers, and especially because whiplash and neck pain generally, it's a hot button topic in various different things. It's the obvious bridge that occurs between clinical practice policy, governmental things that you've mentioned there, and the politics around it, as well as the sort of social consensus that sways with public opinion over these things, and it's very, very complex. So you've mentioned that your neck course has become more of a neck rehabilitation course, whereas from what I understand from the research we've done, it was more named and framed around whiplash initially. So has that been a natural migration with the evidence, with your thinking? How did that sort of migrate that way?
So, I mean, I guess I was interested in, looking into the whiplash work and getting involved in the medico-legal area, purely from a business perspective initially, from the work, from doing medico-legal assessments. Right. I was just going to try to branch out in that area. So the teaching followed from that. I think the thing about the whiplash literature is it costs economies so much money. I mean, it's £3 billion a year, this country alone. And there's an enormous amount of research being carried out into whiplash. And I think, it probably equals the low back pain literature in terms of quantity and quality. So there's a lot to get your teeth into. But so I think that was my original thinking around there's a considerable topic here. It's a complex topic, and I'm sort of drawn to complex presentations. It sort of covers the persistent pain, chronic pain area as well, ticks that box. So it's a really interesting topic to initially start looking at. And then over time, the literature sort of suggested, there were question marks over the efficacy of physical therapy input in that area. And the main sort of orientation, the main evidence was mostly for triaging in that area. We can talk in more depth about this, but it's more to do with the role of the physiotherapist as being sort of identifying those at risk of poor outcome early on. So that's why the course shifted. Really, it was in line with the evidence. And also, I felt when I stepped back and look at the neck pain literature, I was teaching whiplash for a long time, and there was more sensory motor work coming out. So proprioception. There's some literature around eye movement control and postural stability, and in terms of gross postural stability, standing with feet together kind of stuff. I'm not talking about spinal stabilisation with respect to that. So there was more evidence coming out around that. But I was teaching this, as the whiplash evidence was coming out. The MINT trial, and there was a trial in Australia on persistent neck pain in whiplash, the PROMISE trial. Very, very large studies. That was putting a question mark next to physio and its contribution. Did it make a difference having hands-on treatment, having managed interventions, 6, 12 sessions, 24 sessions in some cases? And it appeared it didn't make a lot of difference. So it was kind of that and questioning that and what I was teaching really. And for a long time I felt that we were sort of stuck at the impairment level. So I draw these parallels now, and it occurred to me slowly over a period of time that if you had an ankle sprain patient come in, you wouldn't just do sort of active range of motion and a bit of TheraBand in one direction, dorsiflexion resisted TheraBand, and maybe check their one leg balance, unless they went, that's it, And perhaps that's as far as the literature went for a long time, and certainly still goes when it comes to neck pain. If we take these sensory motor findings to their logical conclusion, and a lot of the muscle performance stuff as well, it's all kept in silos, and if you find something wrong with this particular muscle, you address that particular muscle. And you'd never do that with an ankle or an anterior cruciate post-op rehab. You get people into functional positions as soon as you can. And this was quite enlightening to me. And there's nothing really in the literature. There are obscure chapters in neck pain physiotherapy books over the years, where people have just touched on stuff. And there's this fantastic line from one chapter from, it must be 15, 20 years ago, that says that the neck subserves the specialised sense organs of the head, and that was just like an incredible revelation to me that this author, who was an orthopaedic surgeon, was actually saying, we move our neck because we want to smell the coffee and knows what's going on over there, or listen.
Track predators.
Yeah. So it's that should be the starting point of rehabilitation, and we would do it with an ankle and a knee, and then indeed when you address function, it's enjoyable rehab. There is a vibe about it. You get feedback. It's enjoyable, and you really feel like you're changing many different areas of the person's presentation.
I can tell we could go straight there, because that's such a, you're right, it opens a door into such a liberating rehab field, doesn't it, when you move past the impairment model. But I'm conscious not to rush too quickly. Just to finish up a little point on this bit, because your journey, I just feel, is intriguing, almost a podcast in itself. But was there a moment in which you were sort of your bias was confronted? Because I know mine was. When the whispers of the MINT trial sort of came forward, and then we started to think, well, does physio matter? We could argue. It was one of the things that got asked. Was there ever a point in which it really you felt your shoulders tense up and sort of think, well, they're coming for my job, and the evidence really slapped you in the face?
Yeah, because it was comparatively speaking, it was an avalanche. There was a couple of acute trials, and these are big, expensive trials. You've interviewed Professor Lamb on this program. These are multi-million-pound trials. They're not small feed. The MINT trial is one of the largest cohorts of whiplash patients ever been followed, I think. So I felt like there was a lot of questioning going on, but that's the nature of our position in society. Really, is to have the rug pulled from under us, and you better get good at getting up again.
Sure.
Yeah, it happens.
Yeah, that's true. And did it ever at that point feel, not in a specific sense to you, but did it ever? Because I suppose maybe I'm projecting a little bit here, but did it ever feel like a hatchet job, or feel like there was a way in which you saw this is just a calculated way in which they undermine the way in which we've done things, and then it's been constructed in such a way as to there was an inevitability to where they landed?
No, I don't think so. I mean, there are shortcomings with these studies,
But we poked at them when we chatted this out.
Yeah, that's right. So I mean, they started taking patients in 2005, I think, so it's 12 years ago, and there was only so much evidence at that point. But if you look at these studies, they're just using very light rehab, really, if that at all. It was very hands-on. It was range of movement exercises, and it was just one movement interflexion, I think they were doing in the MINT trial. 10% got proprioceptive exercises. But then there are other studies that have used very full-on rehab interventions and triage people, and it shows similar outcomes between usual treatment.
And that was the thing with the Aussie trial that soon followed, wasn't it? It was like, well, let's just hold the horses and
see.
This sounds like more good stuff.
Yeah, that's right.
And then when almost a damp squib outcome
that's
to
right.
that as well. So
Yeah.
I remember it was an interesting time. So yeah, great. And I'm sure thoughts in and around that we don't need to separate, because this conversation will naturally flow. Because one of the biggest things I wanted to make sure we just touched on before we get into the really interesting stuff with the rehab is with regards to diagnosis. Because over the years, and especially even now, there is still, if we had to, you could draw lines between how, when it comes to diagnosis, the specificity of diagnosis is how I'd probably word it.
Yeah.
So where do you stand on it with patients with neck pain? So if I just sort of picture a line with those that perceive that the C4, that, well, it's almost couched in subluxation theory even, but the idea of motion palpation being sacred, versus those that just say these are all just neck pain patients, and therefore that is one big umbrella group. And people obviously go further than that and just say pain patients. They don't need to necessarily care if you go far enough on that trail. So where's your position on the specificity?
So I think my take on anything I do in the clinic, I depend 100% on the research as a map, and to give me some guidance. And we know over the years you have these studies where people have palpated the neck or examined the neck, Joel's early study, and then they've done medial branch blocks, and they've seen if they can identify that level. And there are shortcomings with these studies, because there are huge false positive rates with medial branch blocks. People say that it has worked when in fact it's probably a placebo effect. There's more recent work which I base my clinical examination on, and it's a very rigorous trial. It's by a guy called Greg Schneider out of Calgary, University of Calgary in Canada. So, and he looked at a cluster of tests, basically, which I think is a sensible approach. So he's looking at a physiological movement, and he examines the muscles over the facet for tenderness and a pain rating, and he looks at mobility of the facet. So he puts pressure on it. Does that hurt? And how much do I think it's moving? Does the physiotherapist think it's moving? So there's the physiological movement's extension and rotation. That's a peculiar one. I don't know why they chose that. I've not seen it in the literature before. So they actually got the person to actually extend and rotate to one side, then the other side, and said, does that bring your pain on? Then they would lie prone and palpate, basically a unilateral PA over the area. A rough, I think they divide it into three categories. Is there any movement? Is there normal movement? Or does it feel like it's in the middle somewhere? And how much did it hurt out of 10? And then palpated over the muscles of that level. And those together, those three tests together, show really high levels of specificity and sensitivity compared to a medial branch block. Now, what they did with the medial branch block is what the international guidelines suggest, is they used a short and a longer acting anaesthetic into the sensory nerves over that level. And so it's lidocaine for more than an hour and bupivacaine for more than 3 hours. And if they respond, as you would expect with relation to the chemical properties of the local anaesthetic and the anaesthetic that's been used, then they would say, yeah, okay, this is not a false positive result from the medial branch block. So I think there was something like 125 people in that study, I think, and that's something I'm happy to base my practice on. Literally using that as an opener to try and diagnose facet joint nociception. Sure. Having found it, what do we do now? But I'm happy with that as evidence. Joel's study was 100%, and I think there may have been some false positives within that. Sure.
No, I think that's certainly a smart middle ground to tread. It's quite different to, because especially when it comes to the way in which symptoms are elicited, it's quite different to asymptomatic motion palpation. So do you, I suppose, taking the position you've just outlined, which is, as I say, a smart one, do you find yourself distant enough from people that are sort of the asymptomatic motion palpation, that segment is relatively stiff, to the one below it, above it? Do you distance yourself from that in a certain way? Have you ever been there? Is another question. I think I certainly have personally.
I've been there.
I wanted to be that guy for so long, and equally, do you price yourself from anyone beyond that won't necessarily buy even the specificity you've outlined?
Yeah, so I've been there identifying stiffness, but I'm not there anymore, because I don't think you can do that. I think, if we look at something like the flexion rotation test, and we discussed that with Toby in his podcast with you, I think there's science behind that as well, and identifying movement at one specific level. It's a very specific test that I'm happy, and I use that in neck pain patients also to look at movement at C1, C1, 2. But in terms of palpating for stiffness, I mean, no, I don't. I don't do that. I might do it in a specific person on a specific presentation, but I can't think of an example coming to mind. It's not common at all that I would do that in my practice. It's all pain related, and I'm looking for sensitivity in different parts of the spine, basically. Yeah.
So it's moved away from that, sadly.
For me, yeah. I mean, I did the combined movements courses. I did my MNIPS postgraduate diploma. So I've been there and done all that. But I don't use that to palpate for stiffness anymore.
Yeah, and I suppose one of the questions when we talk about movement away from certain things is I should always, and forget to, follow up with, have you then noticed have you done so and seen your practice suffer, your outcomes suffer from that? Do you find yourself missing it? I certainly miss the smugness that used to come from it, thinking that I was magic. But beyond that, I certainly personally didn't find that compromised my ability.
I think, I did my MNIPS 15 plus years ago, and in that time it's probably decreased exponentially every year, the amount I have used it. I'm not saying for a moment that I don't use it, and I find it very useful, but it's become much more sort of targeted as the evidence has mushroomed in the background, dealing with the whole person.
Absolutely, yeah. Everything else cropped up, didn't it? So that's a fair point. So to traumatic neck injuries, namely whiplash, which we've touched on already a little, what do you consider to be essential assessment factors, both subjectively and objectively, when someone presents to you straight out of the gate, so you know little of them, apart from the fact that they've had an accident?
Okay, so the main areas that come out of the literature are and won't be surprised when I'm not sort of psychological factors in terms of identifying those at risk of poor recovery. You're looking at psychological factors, and you're looking at pain levels and disability levels. So you're looking at someone who's got. So this is the most important thing you do with someone who's suffered a whiplash injury. Are they experiencing high levels of pain? And I think the literature suggests that's 5.5 or more on a visual analog scale. It doesn't seem that high to me. Then I feel more comfortable rounding it up to 6. But anyway, so that's the cut-off, if you want to cut off in terms of pain intensity. There might be features of neuropathic pain as well. So they'll have electric shock-like pains, skin might be mottled around that area, burning pains, hypersensitivity of the skin may be a feature. There's evidence that a third of whiplash patients will suffer some component that's neuropathic pain in origin. And then we're looking at high levels of disability. So that's measured using the Neck Disability Index score, a very commonly used outcome measure in the neck pain literature, and a cut-off's around 40% on that. So they're pretty disabled, they've got pretty high levels of pain, may have neuropathic pain component. And then we're looking at the psychological risk factors. So we're looking at things like the usual musculoskeletal suspects like catastrophization and fear of movement. Also what's more important with respect to the trauma is a post-traumatic stress reaction. And this can easily be overlooked, and on my course I give a case study where I missed it in a person who'd had neck trauma in a recreational setting out on a bike on a Sunday morning. And it took me a few months to realise that actually this person wasn't getting better because, eat humble pie there, but it's very easy to miss. And if there's one thing people take away from this podcast, it's to consider the post-traumatic stress reaction after trauma, because it will block physical recovery. And it's relatively easy to screen for. Yeah,
you've written... I encourage, if listeners haven't, to read your blogs, but one of them that's just ringing a bell right now is one that you wrote on the questionnaires, or just the sense that it felt like this is evidence-based practice, therefore fill out this folder that will take you a week to do. And you made a great case there for making sure we don't think in algorithmic terms okay, let me take that from you. I could have a conversation with you, but I'm going to put that on hold while I do the arithmetic. It's so weird to us all, and so it should be, at least. In doing so, I imagine that you've then found a way to, find the way between the subjective and the objective way in which we're eliciting this information. Which surveys, questionnaires, sort of thing, do you therefore lean on straight out the gates when someone presents to you? Which have you then decided that you park and only use maybe specifically?
That's a really good question. I'm glad you brought it up. So the only one I really feel I need to ever have to use is the screen for post-traumatic stress reaction, because I'm not a psychologist and I can't interview someone and pick up, is this person or is this person not showing signs or symptoms of a post-traumatic stress reaction. So that would be the impact of event scale, the IES, which has been around since the late 70s, and there's a cut-off for that. And you don't screen before 4 weeks, because there can be it can manifest and be there, but it's not clinically relevant. It will settle in that first month. But if it's not settling after 4 weeks, you need to screen, and they need early cognitive behavioural therapy. The evidence suggests that's effective. with a clinical psychologist. So that's the most important one. And you're right.
To every patient. So just to clarify.
So if you think they've got symptoms of post-traumatic stress reaction.
Right. So even then there is a specificity to that. I suppose I'm just meaning is there any blanket waiting room style thing? No? Good.
Not at all. No. That's not to say there wasn't in the past.
Sure,
the blog suggests that, and indeed, if you look at this area, it's useful to get see what the questionnaire comes up with in terms of compared to what you're picking up from an interview can sometimes be a useful training thing. You don't have to do it 2 or 3 times. But my suggestion to practitioners, and a lot of practitioners are being swamped by these questionnaires. And when I've been at conferences and people put up 5 or 6 questionnaires in a row that I'm not familiar with, and it's just overwhelming. You can't follow it. There's just so much content in these questionnaires. But my take on it is just become familiar with the language of one questionnaire. So it would be the pain catastrophizing scale for catastrophization, the Tampa scale, kinesiophobia, the TSK, and there's shortened forms of that now for fear of movement. Those would be the main ones that I would suggest practitioners become familiar with. And it's just a matter of writing down the questions and starting to pick up if the person's using this kind of language, or you can start to probe, either during the interview or when you're examining someone. And
the fear that I suppose we should all have, those of us that care about broadly speaking, the line between subjectivity and objectivity and making sure we don't wield numbers over patients, is that I don't think it's beyond the pale to think that there would be physios out there that are saying, I hear what you're saying with this narrative that you're telling me, but it's contrary to the spreadsheet that you've just helped me to fill out. And that essentially, which is simply a numeric version of, you would hope, their narrative. And I think that people feel almost conflicted by it, whereas it should be an assistance if you require it to add clarity to the conversation you've just had. Now, so it sounds like you're potentially, where you see fit, drip feeding these, I keep nearly saying spreadsheets, they're not there, questionnaires into as part of your package of a subjective assessment, or even anywhere as part of a treatment plan. In doing so, do you look for ways in which you think that would be just a particularly helpful assistance to me as I'm reasoning things? As you're moving the parts as reasoning occurs, shall we say, do you then think if there's a jigsaw piece that might assist me, or is it more that as something emerges, or this particular trigger words that you might think that would be a useful thing? What's going on in you, if you don't mind? Can I get an insight?
No, of course. I don't use them much anymore. I don't hardly use them. I use the one where you're looking for a diagnosis of a post-traumatic stress reaction, and I'm listening for the language. But you raise a really important point, and my view on it is, catastrophization and fear of movement, they're theoretical concepts, and they must never forget that. And they represent us just scratching at the surface of what's going on with any one person. They're just one way of looking at things we think are currently important. We'll come up with much better ways in the future. So they are instruments and tools, and we must not be slaves to those at all, because that's not the way forward. But the language is useful, and catastrophization is an incredibly useful clinical concept. It's showing important implications across the board medically, isn't it, in terms of surgical outcomes, etc. So I think it's a language. The language in the questionnaire is important for clinicians to learn, but it's not something I turn to anymore, really.
Okay. I suppose I'm just trying to think, can I frame that question again in a case study? Well, I'm completely happy with your answer, by the way, but I'm just meaning, if I was sat in front of someone is presenting and describing a car accident, rear impact, a classic whiplash, and then they were I'm finding it difficult to tease out their story. They were coming in, potentially sitting there thinking, why are we even having a chat? Surely I should be having me rub now. We know the sort. And they've got a monk on, going through the motions, they'll tick box, yes, no answers. And I'm in a situation where I've seen behaviour as they've come from the waiting room that might indicate either that there is some acting up behaviour, or that they genuinely are just very much avoidant of movement despite some time passing. I almost feel like then I would, not saying I do this on a regular basis, but then almost like a TSK would help me to reach behind that and give me some insight that then maybe this person would be able to help me with more than my eliciting of information would. Would that be?
Yeah, absolutely. Absolutely. It would be appropriate if you think it might trigger conversation. Indeed, when I used to use questionnaires, indeed when you use the impact of event scale, it's often people will come back and go, it really gave me pause for thought, and I could actually see in almost objective way by looking at my answers the state I'm in, whereas they've not been aware of that to that level up until that point. So often, it can shift things around if you feel that's needed in a clinical setting.
Yeah, it's a fine line because it can piss people off as well. Not just because of the volume, which you touched on in your blog, but also I know words and I know what kinesiophobia means. You think I'm scared of movement, therefore I just need to move, but it hurts to move, and it can sometimes, you pick the wrong person, it flies people up, and if it is a dossier that they have to fill out in the waiting room before they've even met you.
Yeah, that's right.
It's not a good idea, is it? So no,
it's not a good starter.
I've got a sense that, and partly because it fits my bias, I suppose, that I asked the question saying subjectively and objectively, what do you look out for? And you've answered it not in two parts because it almost feels as one with that assessment. Yeah. Is that because it fits my bias, or is that kind of how you see it? Is that you don't draw a true separation? You're looking for behaviours with your hands, your eyes, you're discussing it.
No, that's absolutely right. I mean, one thing we haven't mentioned is central sensitization, so widespread tenderness around the body.
Yeah.
Following after a whiplash injury to the neck, where there's been no injury in, say, the lower limbs, and people are tender in the lower limb area. This can be, another sign of poor outcome, the presence of central sensitization. So. It sort of fits in with what you're saying, this mind and body and psyche and soma division. It's another construct, and we are just one thing. The catastrophization is the pain, and the pain is the catastrophization. They're all just one thing. We give them words and break them up into components. And I think, from the point of view you just outlined, it all just flows together. I mean, hopefully it does sometimes, but it's real life's not often like that. But I do acknowledge, and there's research to support the fact that decreased psychological distress and physical central sensitization can reduce, and areas become less sensitive, and likewise the other way. If you reduce nociception, it reduces catastrophization, and it reduces post-traumatic stress reaction as well. So it's all one thing. We're grabbing hold of the same thing. It's just all the nervous system, the mind and the body is one thing. But I mean, in terms of objective, strictly speaking, I would look for widespread tenderness if I was screening for risk of poor outcome in whiplash. There's no how stiff your neck is, how good you are at doing the craniocervical flexion test, neck strength, motor control variables, I'm doing quotation marks in the air here, motor output has no bearing on recovery from whiplash injury, as crash-related factors have no bearing on whether you will recover or not as well. So these physical parameters.
Are you fussing over, I mean, I've moved away from it, but then I'm almost, as we're talking, thinking, have I moved away from it too readily? I used to be very fussy over where were you looking when did you spot them coming, did you brace, were you anticipating it, what exact angle, did you have the police report? I didn't quite go into ballistics, but I was
went far off. It was an A4 side.
So in doing so, do you still find yourself asking those questions? If you do you do it out of obligation, or is that, am I right to have moved away? Should I be feeling guilty for moving too far away from those sorts of variables?
I think in a clinical setting, they're of very little use. They don't predict recovery or non-recovery, crash-related variables, simple as that. I might want to know, sometimes if they've seen it, it can have psychological repercussions, and maybe they've got a child in the back, they're stationary and there's a lorry coming towards the car. I've had situations like that, which are absolutely horrific, so that might be a reason. And there's a small experimental, I think they took the facet joints out of the cadaver's necks and did some strain testing with it rotated already, and it showed that there was more injury, shall we say, to the facet capsule with it already pre-tensioned, and that kind of makes sense, doesn't it? If you've got a joint positioned near end range and you add an insult to it, it's going to be more injury. But
that would be particularly unusual, wouldn't it? I remember that work being done. You think, what's the context in an accident that someone's not just seen them coming, they've seen them coming, turned full, turned all the way around, got to confront them almost like a warrior.
Yeah, bad luck. Yeah.
That would be strange. I think it'd be clumsy if we just. There are other podcasts in which I would direct people to if they wanted it in more detail. But it'd be clumsy of us if we shot past some of the more serious consequences of neck trauma that need to be clarified, namely vertebral arterial dissection and cervical instability, sort of DENS issues. So if we can just touch on that sort of, not necessarily your position or just what you're looking out for.
Yeah, sure, yeah. So I would add fracture as well to that, cervical spine fracture, which is again profoundly rare. So cervical arterial dissection, we're looking for, and there's a suggestion in the clinical studies that there's an increased prevalence of this following whiplash, following trauma to the neck. So we need to be very suspicious, and we're looking for, if we want to sort of a tick list of things to look out for, we want to be suspicious of high levels of pain. This is unlike anything I've ever had before, might be the kind of words that are used. It may be presenting over the vertebral artery, so posterior part of the cervical spine on one side up into the occiput, or the carotid artery, which would be anterior up into sort of the mandible and the side of the face. And there may be dizziness, double vision, drop attacks. There may be paresthesias in the face. There may be all sorts of neurological symptoms arising from that due to ischemia or a blood clot in the cervical arteries. And there may be Horner's syndrome, which is constriction of a pupil, drooping of an eyelid. and loss of sweating on one side of the face. So any sort of neurological sequelae or anything that feels like it's not a typical soft tissue symptom, then be very, very alert to this. And I've seen people in medico-legal cases where they've had this allegedly arising from physiotherapy treatment. So if there's any symptoms beforehand, you need to be very, very thoughtful about what you're doing with the neck. And it doesn't just mean, are you manipulating or not? It's, are you mobilising? Are you even moving the neck?
Yeah, you
more
assess it.
It's
a great point that Alan Taylor made on this show when he was on a couple of years ago now, and he was saying that really it's a reasoning process that means that why would you take that person to end range when you're doing an assessment of them, never mind manipulating them.
Absolutely.
And really, I feel like I'm channeling my Alan Taylor to say, acquaint yourself with the cranial nerve testing to make sure for thoroughness, and then move that on before you start wiggling them about regardless. Don't pose that thought, just to make sure you act on it. What about the other things then with regards to spinal fracture? I suppose one that I didn't say would say like a significant and acute disc lesion that would be compressive, for example. The younger person would obviously want to act on fairly quickly, wouldn't they?
Yeah, sure. Yeah. And the fracture would be, I use the clinical prediction rule, the Canadian C-spine rule. So basically, if someone's ambulatory after neck trauma, it pretty much excludes a cervical fracture. But you always have these people who come in, maybe it's just 2 or 3 weeks, and they've got a really stiff neck. So range of motion, rotation of less than 45 degrees can be sign of fracture. But then you've got, becoming more aware of the older adult, 65 plus, is another danger zone. The risk factor because the bones aren't as strong. And the mechanism of the injury, were they on a quad bike with no helmet, or what were the forces involved? Did they fall down 5 steps, or were they on a bike? A bike's quite a high risk factor for cervical fracture. So the C-spine rule is very clear, and it's a nice algorithm to use, and it picks up a fracture if it's there.
And that will be available to listeners on our Google Drive page. So always worth just pointing people towards those things. And anything else on sort of your cervical?
Yeah, so
because that's where it becomes a greyer area, doesn't it? Where we're sort of, it's not quite comfortable, but equally this is something that might clear in a few days. So it'd almost be too risk averse to say, well, I'm going to hold fire. Because we don't want to go too far that way either, do we? Where we're spotting too much seriousness.
Yeah, that's right, And that may be a reason we've not rehabbed the neck as much as we should, because perhaps this is an unconscious thing, I don't know. And we can come back to that, maybe. In terms of upper cervical ligament damage, if we look at the studies, there's been some pretty good studies using higher resolution MRI in the acute stage after whiplash. So early studies were mired in poor MRI resolution, chronic persistent pain following whiplash, and they weren't compared to control groups of no pain or just insidious onset neck pain. So these ligaments looked different. So the conclusion from the research was, oh dear, this represents injury. But more recently, in the acute phase after whiplash, high resolution scanning demonstrates no difference between normals and insidious onset neck pain, atraumatic neck pain. So it's not something I see in my practice. It's not something I routinely test. But my sort of take-home message would be, with medico-legal hat on, is sometimes there's a rabbit in headlights phenomena when people identify red flags. And then we're talking catastrophe here. If someone has a stroke, this has huge effects on someone's life. We don't need to be told about that. We've all seen the consequences of stroke and other pathology, serious pathology. So my take-home message is always, if you're even the slightest bit concerned, talk to a colleague about it. Just go and have a chat about it. Just get it out in the open. Because you see in notes, people will write down red flags and just carry on, basically. And they sort of clinically reason it away. And I don't know if this is just something to do with our profession or human nature, but because we think these things are rare, we think they don't happen. But I think Roger Carey said once, rare things happen to people. People win the lottery.
Of course they do.
So, and it does happen to physiotherapists and clinicians.
One of the reasons that I've such a bee in my bonnet about an openness of dialogue across everything is because I can so see our circumstances when I was a junior, that where the context in which you were in clinic and the way in which you were getting on with your seniors, or the way in which you were feeling that day, had you just squabbled with the missus just before you went into work, meant that you were going to be naturally less likely to just go and chat to a colleague because you were feeling a bit insecure that day. You might not, and you just err towards not doing. And so because of those variables, amongst other things, of course, I'm not saying it's only that, but that's why that ability, like you say, to just say, let me just run this by you, and doing that at every stage. I'm mentioning then as a junior, I still do it now, and I'm always out the curtains. Just, you mind just checking on this, or what do you think of this, or just ponder it with me. And we need to, for me, I just think that openness culture just needs to be for our own safety as well as the patient's safety. Really.
Absolutely, yeah, absolutely spot on.
When with this post trauma, then big broad question, and we've kind of touched on it a little bit. How good is physiotherapy for those patients? How useful do you think how much use can we have as clinicians with these patients? Do you think?
So I think, again, my starting point would be, the research, and we've talked about the MINT trial, and I mentioned about maybe some shortcomings in that as a rehabilitation approach for what ostensibly we're regarding as a soft tissue injury of the neck. And again, if we in the research where people have been triaged and they've had a lot of physiotherapy, again, there's a question mark as to whether there's a difference between usual care and this triage approach. But there's been more recent work. So there's a background of it don't look like we have much of an effect on the path of whiplash. There's more recent work, and the one I cite is if we're looking from a physical perspective, is Ludvigson's work, which was published last year, and they took a group of 200 people with persistent pain following whiplash, and they put them through quite a comprehensive rehabilitation program. Now, believe it or not, it's only a year ago, but it's the only study where they've strengthened the neck in all directions. So they did rotation strengthening and side flexion strengthening, and showed better outcomes than some of the Queensland studies that looked at persistent physiotherapy and persistent symptoms following whiplash. So there's that to sort of just to give us a little bit of a way forward. So perhaps we need to look at stressing the neck in different directions in terms of rehabilitation. And then some of the studies that have looked at the psychological input for post-traumatic stress reactions shows reductions in pain and disability with in that persistent neck pain group following whiplash. And also we see identifying fear of movement and addressing that in the persistent state, again, it's not the acute state, shows big changes in pain, disability, improvements in self-efficacy. So we see these, and these are quite nice studies, they're not as big as those massive multi-centre whiplash trials. But if you break that down into its component parts, it's still saying, look, we need to screen and identify those at risk of poor recovery. Do they need to see a psychologist for post-traumatic stress reaction? Do they have any central sensitization? Is there a role for neuropathic pain medication here? That's a whole other podcast, I guess. So there's that side of it. And then from a rehab perspective, we're looking at strengthening improves pain and disability in all directions, and we're looking at reductions in fear. So it's right up our street, but it doesn't need 24 or 12 sessions. It needs almost like sort of a precision assessment of, are you fearful, reduce pain, improve self-efficacy, do some multi-axial strengthening, and in all directions, and that is an experiential way of reducing fear, isn't it? So that, I think the evidence is at that point.
Yeah, and you're open to this notion where in some patients, and potentially even a large section of patients, that ticking the boxes of those variables of appropriate reassurance, encouragement of how to make short-term adjustments to their lifestyle whilst pursuing functional rehabilitation of their own making, in certain cases that is a very early and quick intervention that might only need 1, 2, 3 sessions, rather than let's instigate a process in which we need to be companions for a while. So it sounds like you're saying that on an individual by individual level, it will vary in terms of input. However, it would not be, certainly not, I'm not hearing recipes from you, but I'm also not hearing let's go on this journey together and potentially you can get off this journey at some point. You're sort of saying we might not need to embark on this together. We might not be booking a follow-up today.
Yeah, absolutely. Yeah, I agree with that. Yeah, okay. Down to the person really, but be guided by what the person needs, and I'm happy to be a support there or a resource. Yeah. But it's the magic in the physio, in the rehab, appears to be in reducing fear and reducing catastrophization and reducing pain. Has a role. How you go about that, because that's one of the strongest factors in terms of poor recovery is high initial pain intensity. How you go about that, you need to discuss with the person about how they might want to move towards less pain in terms of relaxation or aerobic exercise or medication.
Just to touch on your patient selection point, I was poking at the idea, which I was hearing from you. I thought I was anyway.
No, that's right.
You were quite open to the fact that some will make the same noise as you. I suppose I should be just talking to you, but I'm also, you can imagine there's a weight of other neck chiefs that are out there, and there's a reason you're sat there because I'm into what you're about. But generally speaking, there are still people that will make similar noises. Yeah. But then, if I ask them how many times they, what's the least amount of times you'd see someone, they'd still be saying 4. Okay. Do you know what I mean? Because it's still like, well, maybe we don't need 24 anymore, but certainly these patients need me for at least 4 sessions for whatever reason that they justify. So I wasn't hearing that from you. But you clearly have there is a lower limit in which you're seeing someone that comes in, and we all have them. Not every whiplash patient certainly, but some of them will just sort of hear what you're saying. Your initial pitch of a few minutes of sort of saying, your assessment's good, we're not seeing any serious factors here. We just want to try and find a way to get you back to what you're doing in a confident, comfortable way. And they immediately go, oh, that's great. So do you think I maybe should go back to work then? So I'm unsafe to drive then. And immediately they start to do that. In those circumstances, you're not saying, Yeah, but under my guidance.
And I need to see you next week.
Yeah, don't get carried away. See you tomorrow. Yeah.
Just still be careful. Yeah. It's safe to move, but don't overdo it. Yeah, absolutely. I work in a strange clinic. We high five each other when people come in and we have one session with them, and it goes like magic sometimes. Yeah. That's right, absolutely right. I mean, there's evidence that too much intervention worsens outcome in whiplash, and that's a good quality study there as well. So it's all pointing towards, it's about pinpointing what's stopping this person. It's removing obstacles. What's stopping this person get to where they want to be? And it's often removing things, which often is a conversation or an experiential moving and demonstrating why that hurts, and could they move differently? Can they do this? Or this might help if you do that. It's about solving their problems.
No, that's great. If I would move towards a more insidious onset neck pain, so if we had to put them into categories, I felt like that was certainly smarter than any other diagnostic one. Would be a traumatic onset versus an insidious onset neck pain. How does your assessment differ from those post-trauma that we've just talked on? What are your go-to questions or go-to lookouts? Do they differ?
Yeah. So again, I mean, I use as a map the research, and that would suggest to us that the catastrophization and fear of movement's not common in people with mechanical neck pain. And this is my main clinical neck pain caseload is people coming in saying, I've had this 12 years or 15 years. And my partner found you on the internet, and I'm coming because I'm just spending loads of money on physio and osteopathy and chiropractic. And
one thing you have to get used to from now is that my partner heard you on Physio Matters, and therefore here we are. I can only see that flow through.
Yeah, that's it. Yeah. Okay. So yeah, I mean. That's my typical patient, and if we look at the whiplash literature, which we haven't touched on, it triples your chances of future episodes of neck pain. So it's the strongest risk factor for future neck pain is having trauma to the neck. And they'll often say, I had a whiplash injury 10 or 12 years ago. So my sort of go-to questions, I will ask them how they feel about moving their neck and if there is any fear or catastrophization. And there's often a little bit of fear, which is interesting when we talk about rehabilitation in terms of moving the neck quickly. And often they may get catching or sharp pains that are unpleasant when they move the neck quick, which suggests changes in sensory motor control, doesn't it? It may come up, fear may come up around that, avoidance may come up around that, but I would say it's not common. So it's more of a looking for areas of sensitization in the neck and looking at muscle and sensory motor control, really, muscle performance and sensory motor control. So, my questions would screen for catastrophization and beliefs. Maybe they've had some x-rays, maybe they've had some scans, maybe there's some inappropriate beliefs in there around those, the usual stuff around my neck's wearing out, etc. Or, I found to have this disc problem, and it's useful to talk about, the incidence and prevalence of these findings in normal, healthy people. As you know, that can be very therapeutic, spending time on that. Fear isn't such a big thing, so it'd be cutting more to a rehabilitation model approach.
Because you've reeled off a few different flavours of common myths and misconceptions that we certainly can't blame Joe Public for acquiring, because they're commonplace even within the profession to some degree, or within the industry would be more polite. But generally speaking, are there any that we've not touched on? So do you have a go-to strategy, for example, when a patient, I understand that my alignment's out, or I've got this neck pain, which I know, yes, I've got flat feet, but where have they managed to get that from? But they've acquired a biomechanical an alignment style rationale that they're kind of almost sometimes accepting, but they're still crying out for some help. Do you have a go-to strategy?
So the way I would cope with that, the typical way I would cope with that, is I tend to roll with that, and I'll just note that, and then I may come back to it when I've examined them and talk to them about the concept that we're discussing here, this idea of a sensitization model, that some parts of your neck are more sensitized. You noticed how weak your neck was. You noticed that you couldn't move your neck quickly. Maybe some of the balance receptors in your neck are affecting your postural balance. So I'm looking at you from a bigger picture here, and bring in lifestyle factors. So I would use the weight of the evidence that we found in the session I'd use the weight of the evidence we found in the session to sort of then have a discussion with them about, actually, you know what, in the light of everything I've just said, you've been more stressed, you're a slightly anxious individual, you've not been sleeping well recently, I don't think you're out of alignment at all. And I think that's the way I put it and then they can say, well, actually, you know what, I think you're right. I thought that myself all along.
Or they turn around and say, well, I disagree. I'm certainly wonky, and these are why. No, I think that's a great way to frame it. Certainly, you don't want to jump the gun, do you? As soon as they utter it, you go, oh, well, we need to quash that before we move on. Instead, it's just hold that thought. Certainly, make a note if you're prone to forget, and then revisit it and say, I think these variables are more important. And if someone's particularly attached to that flavour of orthotic or whatever, and they've spent a lot of money in that direction, perhaps.
Absolutely. Because you'll just get them on the back foot, otherwise, and it's not the way to go.
It's not quite getting their back up, is it? I just wanted to check whether, I think we've covered quite a few of them, in fact, but there are several oft-cited factors and indicators of poor prognosis, some of which you've mentioned already, high baseline VAS, history of mental health problems, persistent widespread pain, that this is then an overlay to. And these are, I imagine, all influencing your reasoning. Are there any other particular lookouts, particularly on an insidious onset pain patient, that might deviate you from what we've talked about with regards to the trauma patient? Because it sounds like you're saying there's certainly more similarities than differences, is what I'm gathering from it when someone presents with neck pain.
With mechanical neck pain. Yeah, that's right. I mean, I will screen for catastrophization and fear of movement, and I'll listen out for that and ask them. The usual things would be, what are you avoiding as a great opener for fear of movement? What are you avoiding because of your neck problem? But I think there are big differences in terms of. I wouldn't go down the high initial pain intensity or neuropathic pain route. There's not much evidence central sensitization is a problem in mechanical neck pain either. So those kind of variables are less likely to be a feature. There's some evidence that anxiety and depression play a role, as you said, and poor general health as well. So these would be things I would ask with a mechanical neck pain more so. And in terms of objective stuff, it would be, when a test, it would be looking for things like muscle endurance, which can be a predictor of neck pain as well. Reduced neck strength can be a predictor of neck pain. So I would think it would be more biased towards a physical, with a bit of a screen of the psychological status.
Sure, yeah. No, and the prognostic, a lot of these prognostic factors that I'm talking about are certainly the evidence is more towards the trauma side of things.
Yeah.
Isn't it?
Yes.
Than not. Yeah. And so we're walking towards the real the suspense to get to the real good stuff. But before we do, still there's one more. Certain body parts seem to attract certain trendy treatment techniques, and the neck, I think, is a playground for literally every flavour of adjunct. For various reasons, I've got loads of different personal theories on why. But before we get to the interesting stuff, we're going to talk about the functional rehabilitation, and it sounds like that's everything's pointing towards that. Before we do, can we talk about any go-to techniques that you might have? Which I don't mean here's a favourite and therefore write it down, but I'm just meaning that are there certain things that you do and therefore that don't do, and have you done before and then no longer do for whatever reason?
Yeah. So. Again, my starting point would be the research, and the research suggests, and then this fits in with the rehab model that we'll be discussing in a moment. It's really based around what do you find from a muscle performance and movement perspective. And as with the lumbar spine, which everyone's becoming more familiar with, we get the necks are often weaker, so a lack of strength, decreased speed of movement of the head and neck. So if you're asked to follow a moving object, you'll move your head more slowly. And there will be impairment of certain movements, so craniocervical flexion or deep neck extensors, so these muscles that produce these movements will be impaired. And so I work very much towards anything I use technique-wise will be almost like a coach to try and facilitate those movements, move towards a more normal speed of movement or craniocervical flexion movement and active assisted movement. There's evidence of rigidity, in the superficial muscles as well. I think when people with neck pain stand on one leg, they get something like 60% of maximum voluntary contraction in their neck extensors. When it's normal, it's 10%, 5-10%. It's just ridiculous, inappropriate use of muscles, which can only make your neck hurt a bit more. And it's to do with using techniques to relax the neck, really, oscillatory movements. I like the cervical lateral glide technique in supine. If someone's having a difficulty just switching off the muscles, you can oscillate the neck in that way. But I ain't thinking of foramen and opening and shutting and facet joints gliding. It's all based around moving towards this relaxed movement of the head and maybe occasionally targeting certain muscles. But we can come back to where they sit in this idea of rehabilitation of the neck. Yeah, so I don't do unilateral PAs anymore. I may on the upper cervical spine, I may with headache patients, I may with dizzy patients, nags and snags and upper cervical spine modes. But in terms of mechanical neck pain, there may be areas of sensitization over facet, and I may use some techniques, literally just like a cross-friction technique on the facet capsule. It may be quite painful doing it, so I will say to the person, this may desensitize this during the session, give you some pain relief, and we'll see if that improves your movements. And use that as a kind of touchstone experience in terms of facilitating these kind of movements I'm talking about. But it will be couched very much, approached carefully, and couched in this rehab model where I found these things, but you can change them. The great thing is about these things is you can change them, and the other great thing is it reduces neck pain.
You're describing a cluster of manual therapy techniques there that are very specific and individualised. When I say specific, I mean to the individual rather than in a mechanistic sense. And your reasoning there, I can completely understand. I know you're friends with ex-podcast guest Neil Langridge, who's our most popular podcast now is the one we did. It was still only this year, which is crazy that that's still overtaken all the ones before it. But one of the reasons why it was so popular was it was couched in this facilitatory. These aren't active versus passive. These can be facilitatory techniques. But to do that, we need to get it away from this mechanistic or here's the pain relief. Now let's do the rehab. No, this is to assist the rehabilitation in as particular ways we need. That whilst I'm hearing that from you, and I totally agree with it. There is also then people will try to administer a technique as a means of pain relief, and therefore you're describing manual techniques. Are there things therefore that you don't do? Do you tape the neck? Do you acupuncture the neck? Do you manipulate as a means of just let's get this more comfortable in order for us to do things, and have you in the past?
Yeah, so I used to tape, but I don't tape anymore. That's not to say, when I go back to work next Monday, I might put some tape on someone if I feel it's appropriate, but it would be very much down to that individual. Have they found it helpful in the past? But it's not something I would go to. I do use acupuncture, so I might use that on a patient who needs pain relief, basically, and maybe they found it very beneficial in the past. It's not something I use an enormous amount of. In terms of neck pain, because the evidence isn't that good, and I may use it in this is not much better than placebo, and they may laugh and say, "But it works for me," and this is the and that's the context in which I use it. I don't think it would work.
How often there's a typical rule, and so on a typical week would the needles come out?
It'd be a tiny percentage,
Sure.
And it's always couched in this, it's buried in this rehab concept of looking at everything else, and that this is giving you some pain relief, and people want pain relief sometimes, and if they've got a favourite type of pain relief. I may use that, but it's always returning to that point. It's not like I'm seeing someone for 6 sessions once a week, and how you're doing with your list of exercises. It's not like that at all.
Would you be the first to introduce? Because I find it easier to comprehend, and I think I had this chat with the Val Hotwood when she did an acupuncture podcast. But it was like I can comprehend when someone has acupuncture is their favourite flavour of pain relief. Keep all the medicine away from me, and I want this. There's a difference between, okay, then let's do that as a means, like we said, of facilitating the next 10-15 minutes of the session. There's a difference to that than I feel that would be a sensible move, and you're the first to introduce needles to that conversation. Where do you stand on that? Does that happen?
Yeah, it'd be unusual. Remember, I've been in my practice 15 years, so I've got rid of the people who are having interferential on their lumbar spine now. I think they've all died, or they don't come back. I managed to wean them off of that, but this is one of the problems with changing practice, changing evidence, and you've got people who've got something they swear by. That's one of the balances. So to answer your question, I think it'd be unusual if I used that as a first. It'd be very unusual. I can't remember the last time I did that. If I used that as a first treatment option, because it's just not in my frame. As we've been discussing, mobilising the cervical spine's not in the frame anymore. It doesn't make any sense. It's abstract treatment. It's pulling people's attention away from something that. They need to concentrate on other things, the evidence suggests. So, so it's
cervical manipulation still. Because I suppose just to bring it back to where we were as well is that in defence of the MINT trial, it was relatively representative of what was happening in therapy at the time.
Probably still is.
I would agree with that. I think I've reflected on that episode a lot for various reasons, for the feedback that came in good and bad flavours from it. But it's a while ago now. But the reason that I think that the trials like that should be almost forcibly, not through legislation, but committed to repeating it 10 years on. Or where obviously the evidence is somewhere between 16 and 18 years as to implementation, is that has this been acted on, and if so, can we repeat? If it's a trial that is suggesting that this is what is going on and let's compare it to a minimised control, then why not repeat it? And that almost should be sort of in its script, and maybe it will. But the only reason I'm bringing MINT back up is because we kind of know that it's commonplace for manipulation to be a first line go-to, and it isn't, unfortunately. I don't think, at least feel free to disagree, couched in this facilitatory reasoning that you're describing. And one of the reasons why Neil's podcast was so popular isn't because it just sat really well with everyone. It went semi-viral because it's something that was this is something that is couching the reasoning behind this in a different non-mechanistic way. So with manipulation, then, do you find yourself? Is it straightforward, I suppose, is the question, to get people away from what feels quite an intuitively mechanistic thing when you have your neck cracked? What did you put back in there? And do you have any go-to tips for people that do have difficulty sort of reframing either their own practice or what has been done to the patient before?
Yes, I mean, you have to couch it in a neurophysiological context, don't you, that it's going to offer some pain relief. And it's that simple, really. There are things I can do which can reduce your pain now. And make it feel more comfortable and help you do your exercises more effectively, help them progress a bit quicker, hopefully, because they'll be more comfortable doing them. But this is short term, what I'm going to do. And so there's nothing, I don't think there's anything I can offer with a specific reference to manipulating that I wouldn't say about any other sort of hands-on approach. Because as long as it's happening in that context, I think there's evidence to support its use. It's when it's used on its own, we all know that the downside of that alone. Hands-on work's used alone in the absence of any other, even from a critical reasoning perspective, it doesn't make sense to just keep repeating a bit of pain relief.
Or if it's not couched in the appropriate information that would stop someone associating the recovery directly to it in any sense, really. I suppose that's where my bigger bugbear comes with these sorts of bits. Is usually to do with the not enough has been done to stop this patient misattributing that to their recovery, and because I don't buy this notion that you get this dribble independence, this idea. I don't think there's any evidence to suggest that we're sort of getting people addicted to our hands. However, I think that there is something to be said for the fact that you need to do what you can to help people understand that this is facilitatory. I keep using that word rather than something that's either curative or the type of pain relief that you'll need next time your neck hurts.
Yeah, absolutely agree.
What when facilitating functional rehab, which we're literally about to come to, would you use these pain relieving techniques or manual techniques or acupuncture techniques, whatever it might be, as a precursor in its first instance, or is it that you're going to explore movement with this patient and you're starting to instigate that functional scaling that we're going to talk about that you've alluded to, and you're a few minutes into trying to, I don't know, teach a movement pattern, do a position and technique and stuff, and then you think, okay, we're going to therefore revisit this and offer some relief to then try again, a test, retest? Or is it something that you've anticipated within the assessment to think there needs to be a precursive pain relief administered to facilitate it?
That's a good question. I mean, I will examine someone, take a history and chat and examine someone, and then sit down and have a chat basically about what the options are, and I will say I can do these things, and they will offer some short-term pain relief, and the other, but I think the bigger picture stuff is X, Y, and Z. Maybe it's sleep, aerobic exercise, local strengthening around the neck. That's the way it's up to them to decide what they want to do next. And I've got time to do some today, or actually, your history took up 50 minutes, and I'm actually running late now.
The question is at least an hour.
Your family history took up 50 minutes, so I sit down and talk to them. It's their decision. With the proviso, as you say, that if they want people don't want 6 or 12 sessions of hands-on anymore or acupuncture, but it's couched in that it sort of makes sense. It resonates to people what the truth is, I think, about a condition.
Sure.
And often it's a revelation to them as well, I think. Often, where we're at with our work, I think we're offering things that are very different on when we look at all these factors involved in musculoskeletal pain presentation.
I agree with that. And when I'm talking with journalists and things in the media, I'm often, when people are asking how come there's so many myths and misconceptions in and around that, I'm often saying that I don't know, because the stuff that's actually the truth is far more interesting than the weird stuff that people think is happening that's taken for granted. So no, I agree, we're doing interesting things, and so telling it to patients isn't as hard a task as sometimes people think, like how do I get someone away from this reasoning? It's like, actually your myth busting is pretty trendy, just telling them that I don't think it's to do with your flat feet and your stiff C5 facet. So no, I agree with that for sure. So I'm going to open the discussion more broadly on the functional rehabilitation of the neck, which we've kept moving to. The suspense is over. I'm going to start with a really broad question, because I think I just really want your broad take, if I can, on what does quality neck rehab look like to you as it stands now?
So, I mean, when I started reflecting on, we mentioned at the very start about impairment level exercises and assessments and exercises. So if you find something wrong with proprioception, you practice that, or something wrong with balance, you just practice that. And I've been teaching this for a long time. And then if you look at something like the Aspetar hamstring rehab protocol on YouTube, or you read this massive document and the return to play criteria, or anterior cruciate rehab guidelines, which everyone's familiar with, I'd be shedding a tear into my cocoa at night, looking at these things thinking, there's a huge difference between people doing deep neck flexor work in supine and what we're actually doing with our necks day to day, And so what does quality neck rehab look like? It looks more like an Aspetar protocol, where you're setting down foundations from a sensory motor perspective, and then you're moving on to more what that person's requirements are day to day. And so that requires us to look at, again, we can use the research as a map up to a certain point, but then we need to reflect on the way we use our head and neck each day. So, the research shows that there are delays in muscle contraction in neck pain. You get a reorganisation of the neck muscles in neck pain, so you get an overactivity in the superficial muscles, underactivity in the deeper muscles, and you get a rigid motor patterning. So this enormous contraction of the superficial muscles with balance tasks, for instance. You get reduced neck speed of movement of the head becomes reduced. You get impaired ocular motor control, reduced proprioception, and impaired standing balance as well. So in a nutshell, if you want to rehab those things, you need to identify them and start addressing them maybe at the impairment level. So you might want to work on some deep neck flexor work, or deep neck extensor work, or improve neck strength, or improve speed of movement of the head and neck. and improve standing balance and proprioception. But then at some point you're going to have to face the fact that people have to cross roads, move their head quickly, or they sit at T-junctions in cars looking left and right quickly. We step down from pavements, we walk up and down stairs looking all over the place. And that's got to come into the rehab much sooner. And I think that's what it looks like. It cuts to that chase, to that point very soon.
Because I agree with you, and I've never really thought of it this way, but what I'm hearing from you is that they're going to be exposed to this, why not train them for it? It's kind of like, it isn't a return to play that they're kept in cotton wool and therefore they don't cross roads for 6 weeks until you're ready. They're going to do that, so why not let's do it early? And so that makes sense. Where I just want to make sure I just pull the brakes before I forget is, on a diagnostic level, we talked away the impairment model. However, in these specific circumstances, and whilst I understand the difference, we are talking in terms of more particular dysfunctions with regards to muscle strength, difference between superficial and deep musculature. So can we just talk about how you would, not necessarily going back to assessment sense, but just like what meets a threshold for something to be dysfunctional in that? Let's just use the superficial to deep ratio, if we call it that.
Yeah.
Are you looking for overt or subtle changes in that?
Yeah, I'm looking for something that really is obvious.
Right.
So what does that mean? So again, I'll be guided by the research. So if we look at this issue, let's look at the deep neck flexors, for instance, and their interplay with the superficial flexors, sternomastoid and scalene. So over the years I've been teaching it, I can't stand using the pressure biofeedback in the clinical setting, and I know this has been sort of recommended by researchers and clinicians around the world, but it just doesn't work for me, and it's not something I suggest people use in a clinical setting. It's a useful tool to have. It may be useful with some patients, and it's a useful thing, a stepping stone to understanding these movements a little better. But I think the research is clear. It suggests that these muscles, these particular deeper muscles, don't work as well in neck pain, and the superficial muscles become more active. And there seems to be almost like a seesaw relationship. And some very recent work from last year, Deborah Fowler and Gwen Jull's work suggested, the more overactive these superficial flexors are, then you can be pretty sure that the deeper muscles won't be working as well. So there's a seesaw relation, and you can see that. People who've had 10, 15 years of neck pain, they have a wall of muscle. You sit looking at it, and it's there. They're often breathing apically using these muscles. There's often tension even when they're talking or swallowing in these muscles. So there's this rigid motor patterning there. So what the reason I look at that, and I've struggled with this, do we need to be this specific is the question, isn't it? Do we need to test this particular muscle in this way? And at the moment the research is at the point, and I sound slightly disappointed with it, I know, but the research is at the point where you do have to assess the craniocervical flexors, and the suggestion is the deep neck extensors as well, in a specific way, because if you just carry out neck strengthening head lifts or adding a kilo weight to head lifts, so gross cervical flexion, it doesn't improve the speed of contraction of these muscles. It doesn't improve the EMG output, the performance of these muscles during the craniocervical flexion test. So we have to be that specific at the moment in terms of neck pain. And we know that if you do these rather bizarre craniocervical flexion exercises, it reduces neck pain and disability. So we can't get away from the fact if we're just strengthening the neck, it's not addressing all the muscles of the neck. Regardless of what we're saying they're doing, are they stabilising, aren't they stabilising? Those muscles will remain switched off. So you know.
With them, I'm really enjoying your metaphor with regards to the way in which we use the research and evidence as a map, and so to extend on that metaphor of saying that there can be uncharted territory either side of the footpath that's known, and so when you talk of said almost articulated or you could tell a tone in your own voice of disappointment, is do you find in clinical practice that your specificity is less relevant than perhaps the literature is suggesting? Is that almost what I'm sensing there?
No, I think if your question's about, let's talk about craniocervical flexion. I mean, it's found to be impaired it's one of the most common findings I find in persistent neck pain, that movement. People are unable to perform that movement, and all I can say is that this is a test for certain muscles, and if you improve these muscles, which you can easily do over the next few weeks, it would improve your neck pain, and so it's a matter of just doing that. So I am very specific, and I spend time with it because it appears to be so important, And again, I sound slightly disappointed right now.
No, that's fine.
But I think the way I couch these things, and there's a group of tests called the flexor endurance test, where you hold your head off the bed for as long as you can. Normal values around 30-60 seconds in men and women. Some data's up to 2 minutes, and they're a weighted test for extensor endurance. So you put a 2 or 4 kilogram weight on the head and time that to failure. So, I mean, all these tests are very abstract, aren't they? They're not functional movements. If we keep that in mind, our goal is to return people to function, to crossing the road, moving their head around quickly and feeling confident in their head movement. So we've got to couch these in a kind of, I talk about them in terms of the straight leg raise of the knee, the straight leg raise of the leg of the neck kind of thing. They're very much in that category. Let's check your quads. Are they firing off? Can you do a straight leg raise? How does that feel? Look at your quads. Is there a strong contraction? And then get someone up stepping and lunging. And that's something I might do in some knee pain patients, and that's something I'll do with neck pain patients. But it's a stepping stone to getting them moving their neck in a functional way.
Functional for them. We don't necessarily have a baseline for it. It's like, I mean, I feel like I'm agreeing with everything you're saying, but then also just the intuitive skeptic in me, I suppose, is thinking, this is all well and good had we have had a baseline. So if there was a way in which I could just unveil a video and an analysis from 5 years previous when they were an asymptomatic person living in their life, like someone had followed them around like a PI or something, then I could understand that we would then have this baseline control for them. We're having to make a lot of assumptions on their baseline. And so that's where my eyebrows start to raise a bit over the specificity argument. So I don't know, maybe just reflect on my concern there.
Yeah. I mean, it stands up to scrutiny. It really does. And that's the only reason I use it, because I have a problem with it. I can't remember if I ever did transversus abdominis with patients, but I was there when that hit the clinical floor, and I understand the arguments against, and it's spot on what you're saying. Normal values have a huge wide distribution. So where's this person in that normal, and you only have to teach 15, 20 people on a course to realise there's huge variations whether people have neck pain or not. But despite that, I think there's some sort of truths around the test in terms of how much range of craniocervical flexion has the person got, and that's what I would look at. If they can go through a full range of that movement and hold that position without fatiguing, then I'm happy. So there are studies which have suggested you can use that range of movement, which is why I don't use the pressure biofeedback and those millimetres of mercury. It's something coming between me and the patient again, and you can just check eyeball range and see if they can achieve actively what they can achieve passively. And then you move into facilitating the movement if they can't. But I'm not spending weeks doing it, and it's something that changes very quickly. It can change in a week or two, and then you're off and up doing other stuff.
Sure, that's the telltale. I think that's one of the most persuasive things about what you're saying, is that this notion that the specificity can induce a change that seems to really influence symptoms in a sense of someone that's had these symptoms a long time. That it would be a world's weirdest coincidence unless you were to make this case, as many do, of the interaction and the placebo and the non-specific effects. But I'm with you on that. But is there any other indicators that induce more specificity in you? Oculomotor we've mentioned. Are there any particular tests? Laser pens on headbands, etc. have been used, and I've dabbled with myself in the past. Less so now, I admit, with the laser pens. I don't know, just personal thing.
So I will test craniocervical flexion and deep neck extensors. And I will test neck strength. So I may do some head lifts or some resisted tests depending on the patient. Sure. Some endurance tests. I won't do all of those on the same patient in the same session, but these are boxes I want to tick over maybe a couple of sessions. And then I'll look at standing balance and eye movement control. So can they perform a smooth pursuit test, track a smoothly moving object without feeling dizzy, etc. And also proprioception with laser on head. So those are things I will hopefully cover with everybody. Yeah.
And that's joint position sense. So for those that don't know what the hell I'm on about with lasers, just to clarify what we're meaning there, and what positions do you do it in?
So it would mainly be related to their problem. They have a functional, the problem related to their problem of movement. So if it's usually rotation with the neck, I would use rotation, return from left and right rotation. So you're sitting in head neutral position, you've got a laser attached to your head, so you have a starting position, and you're just trying to move into, as far as comfortable, into a rotation movement and come back and return to that same position in space with your eyes closed. So the assumption is this is assessing neck proprioception, or it's termed, as you said, joint position error. So there's often an error between the starting and the finishing point, and I'll do 3 each side and take the average. And if you're sitting 100 centimetres from a wall, you want to be under 6.5 centimetres.
Do you objectify it kind of like the gun range target type stuff, where you'll then put a mark on? Give them the scores, charge them for the piece of paper.
That's another 12 quid.
And here's some K-tape to pin it to your wall with.
Yes, it's the only use I have for it.
Just dreaming up these weird business methods.
I will assess those things. Because the literature says more recent literature and systematic reviews say whiplash, neck pain, people have impaired standing balance, they have impaired eye movement control, and they have impaired proprioception. It's not a surprise to us, is it? No. These things occur, and we don't want to, talking through it in this way. And when you look at the literature, it takes time to look at the literature and discuss it. But we don't want to make heavy weather out of it. We do it really in a reflex way with knee or ankle rehab, and that's the way it should be with the neck. Like you said about the deep neck flexors, I ain't spending a lot of time doing it, but if someone had a knee problem and their quads weren't working, I'd get them to wear shorts at home, I'd get them to slap the muscle and look at it and keep repeating doing this. It's not a big deal, and they'll come back and that their quads function will hopefully be switched on a bit more.
Sure, when appropriate, attending to it more in a specific way, because in that individual it's relevant. just to make sure I'm right in thinking that your specificity with positional stuff with the proprioceptive joint position set. So, example being someone's has a problem with checking their blind spot in the car. So obviously we're in the UK, so people get confused with international listeners. So checking over the right shoulder as we're driving. Therefore, you would be doing that test if that was their problem in sitting. Not necessarily in their car. I don't think that need to be that specific, but generally speaking, you'd be doing that in sitting. Similarly, if there was another problem where someone happened to come in and be saying that I'm really struggling with particular poses in yoga, I know that sounds a bit less specific, but generally speaking, 4-point kneeling might be a more appropriate position to do so. Are there any other caveats to that? Are there any other go-to positions that you feel aren't just because of that person's contextual problem and functional problem, but also because they, 4-point sleep as an example, where it's like anti-gravity, etc. Are there any other go-to sort of positions to do?
Not really, no. I'd always just be guided by the patient.
Right.
You could have a decorator, couldn't you, or someone who's putting up stuff on a ceiling. Electricians are often in weird positions, so you might use sagittal plane extension flexion more with that person.
Sure.
But it's very commonly rotation.
Yeah. When it comes to functional scaling, as we're describing it, are there any particular areas in which clinicians will classically miss and patients wouldn't even think of?
Yeah, so, I mean, one of the things that came out of the research literature was this idea that people with pain, with neck pain, are moving their necks more slowly than people who don't have neck pain. So if you ask someone to follow a fly that's whizzing around a computer screen, and you track the movement to the head, they're moving much slower if you have neck pain. So this idea of rehabilitating speed from a functional perspective, obviously we need to move our heads quickly when we cross the road or at a T-junction in a car. We touched on this earlier, but it's just not something that we think of rehabilitating with respect to the neck. So it's something I've started assessing in the clinical setting. It's very easy to assess. I've got a specific setup I use, and it's something I'll give as a treatment. Literally, it'll probably be rotation that's used, the direction. And basically what I do is I use the door frame in my clinic, and I get someone either to look or put a laser on the top of the head, so the laser beam pointing to one side of the door frame, and they're sitting the same distance from the door, the centre of the door, as the same as the width of the door frame. So it's an equilateral triangle, which means they're just 30 degrees one side, 30 degrees the other side. So they're tracking through 60 degrees every time they do one width of the door, from door frame to door frame. So what I've found is, and I'm just looking at the data on this, is to do 20 lengths of the widths of the door back and forth 20 times takes about 11 or 12 seconds in health. And if you ask people with neck pain to do it, it's just excruciating to watch sometimes how slow they are. Right. And they may not be in much pain at the time. Well, you can't do it if pain's a huge limiting factor. But it just shows,
thank you for that,
if you're stressing the ocular motor system and you're stressing the proprioceptive system to a degree that's used functionally, we don't know what speed we need to use our neck at a T-junction or to cross the road. There's no data available on that. But we do it every day. Yeah,
and we've all had the spondylotic patients that we think, how on earth do you still drive?
That's right, yeah.
And it's because they've got a immaculate lower thoracic spine, usually, isn't it? Where they've come up with these adaptive strategies. But yeah, no, I think that's a great point. Definitely one that people miss. Yeah. And do you dish that out as an exercise then? Is that they go away and practice that and try and then scale the speed and then retest next time you see?
Yeah. Absolutely, yeah. Absolutely.
When it comes to the variant, I mean, I get laughed at for it. Really, one of my not necessarily even end stage, but one of my rehab exercises that I'll dish out for patients with, especially your sporty patients or usually those with kids have got one is a hula hooping for the low back pain, where we might improve one direction or the other, but we won't necessarily combine the job lot. It might not seem functional unless you're a hula dancer, but generally speaking, why not be able to explore all corners? Now, if I scale that up to the neck, people wouldn't necessarily they'd think they were recovered until they went to their favourite rock concert that they hadn't seen for band that hadn't seen for 2 years, and they start trying to headbang, and that's when they realise that, I'm not quite as better as I thought. I think you sound like you agree that people don't scale rehab far enough, but then also you won't necessarily need to keep them on your books until they got there. So how would you advise a patient when it comes to that long-term management? They're at 80%. You both kind of know it's a smart move for you to shake hands and go your separate ways, but you're trying to persuade them to make sure they don't ignore that 20% deficit. What would you advise them and how to scale that?
So I'd be specific about the exercises, and I use a portal that has video links to exercise. A lot of these exercises we're discussing, so they'll have it there in their inbox, or I may print it out if they need that. And I often do email follow-ups. I do that a lot because people are travelling a lot to see me, and I monitor it at arm's length, literally. And I've seen people over years carrying these out, and I've seen them come back for other problems, or they come back with another family member or their son, and they're still doing the stuff. So I think something about functional rehab is I would be pretty sure that compliance would be higher, because people sort of enjoy it. It feels right to them on some kind of level. It sort of makes sense maybe It's
I
not
think
just
that's it
abstract.
as well. They get it, don't they?
Yeah,
They can see a straight line between
Yes.
this exercise and what they do in their life. That there isn't
Yeah.
a gap. It's an obvious line between it compared to some of the more abstract things.
Yeah.
We sometimes have to, like you say, we do in early
Yeah.
stages. We have to sort of say, "Trust me, I'm going somewhere with this."
Yeah.
And often they've
Yeah.
seen the functional exercise emerged from a more sterile
Yeah.
exercise that didn't
Yeah.
make sense at the time, but now that's where we've
Yeah.
gone, I suppose.
Yeah. So the functional stuff, if you break this down, you can break it down into sort of extension components, rotation components, and flexion components. So the most common one, what we do with our head and neck is often we stand with our head still and we move our body underneath. So, you could do standing in a mirror and just rotating your body around your trunk, and you're doing left and right torsioning of the neck, but you're not actually moving the head and neck. So looking at your eyes in a mirror, or you could look at a fixed point on a wall and walk past that wall and keep looking at that, turn around and then come back the opposite direction, still looking at the same point on the wall. And you don't need a lot of room to do that in, so it's not something where you need the side of a gym, and you go as far as is comfortable. And we're doing this all day, every day. When you walk down the street and you see a pair of shoes in a shop window or something that you want, you look at it and you're very interested in it and you keep your eyes still and you're walking along a pavement. Or likewise, you might stepping down from a curb where you have to look for traffic that's coming from behind you on the right side. You're almost turning your head and trunk 180 degrees whilst you're stepping down. Very functional movement, and that's the kind of thing I rehabilitate. Small step, looking behind you, stepping up and down, or looking at an object on the wall, walking past it right and left, looking up to where the ceiling meets the wall. This might be extension, rotation, or pointing at that object. It is very functional, engaging the whole upper limb and the neck in that movement, putting some obstacles around the floor, so you're having to look back and forth at things. But making sure someone actually looks at something when they're doing it, that there's an object there. And sometimes in rehab I get people to print things out that they love. With one patient, it was a saxophone she was into, and so she printed out a picture of a saxophone that she was after and printed that on the wall. So you're really engaging the brain in these things as well. So, and flexion would be an object on the floor, so walking past something on the floor,
When I was first introduced to these things, and I was very fortunate in my fledgling career, I was in a situation where I worked briefly with Mike Stewart, and he said it's evolutionary window shopping, and that's why I mentioned earlier when we were talking about it that tracking predators wasn't because I'm being predated on a regular basis now, but I was meaning in an evolutionary sense. I think it really helped some pins drop, and it also was a good way that Mike was able to introduce Louis Gifford and then zoology and Sapolsky and some of the evolutionary theory that then underpins a lot of my reasoning. But in doing so, I remember it being a really valuable epiphany for me, almost in that sense, where I was just like, why is the neck designed to do that? Is it a slave to the sensory organs, as you mentioned earlier? Similarly, the shoulder is a slave to the hand. Why do we have a shoulder that does that? And thinking in those terms was really helpful for me. Was there a moment for you in which you had that penny drop, or is it something that actually has been within your practice to some degree for a lot longer than, say, mine?
No, it's a good point. Basically, it happened around the time that I was starting to, become aware that I was becoming a slave to the evidence-based literature. And you're looking at the tests that are used. We've talked about tests for proprioception, tests for eye movement control, tests for postural stability, and they would be used as treatments. And it occurred to me that I was teaching this stuff and doing this stuff in the clinic, but it bared very little resemblance to function. What people would then walk out the door, or even as they walked out the door and looked around at me and said goodbye, I wasn't preparing them even for that. So. That's the point. It's about reflecting on day-to-day practice. And I was reading around, and this line from this chapter jumped out at me, that the neck subserves the specialised sense organs of the head, and it was like bang. It was like, oh, wow. It was one of the most exciting things I've ever read related to the neck, I think. It's absolutely fantastic sort of catalyst for me, all that stuff I was thinking anyway.
Yeah.
That you don't see, like we said then, about the patients, people with problems. If you had a knee problem and you were doing some very high jumps off, a 2'6" table into your leg, it's not necessarily functional, but it improves so much around what that person feels around their knee in terms of confidence levels and fear and strength, and it is a functional movement. And the rehab for the neck is just nowhere near that. It's a shadow. And I teach around the country, as you know, Jack, and people say, who does the deep neck flexor test? And I might get 10% of the room, so 90% aren't even doing it. Fine, and at that point, and there's a sense, you touched on it earlier, around what effect does this have? Well, we know it reduces pain and disability, but when someone comes back and they've been doing it, let's be honest, they don't really go, that is the best exercise I've ever done, my neck's pain is reduced. There's no context for it, you see, and the context's got to be functional rehab. There's no evidence about the side flexors of the neck, is there? There's not a shred of research written on that. No one rehabilitates it, do they? No one does endurance tests for side flexion. No one does side flexion weighted tests. When I started doing them, it brings up so many problems, because often neck pain's asymmetrical. So endurance tests in side flexion, you don't need to wait for University of Queensland to suddenly realise there's neck muscles on either side of the neck, not just on the front and the back, for us to rehabilitate them. And that's the position I got myself into. And I think a lot of practitioners are duped into thinking we need to wait, when actually if you just, like you're saying, just reflect on the neck and its function, then you need to activate these things at that static quad straight leg raise level, and then move into functional rehab.
Yeah, no, fantastic. That makes a lot of sense. I think it's really interesting as well what you're saying about how you found yourself chasing empirical answers to questions that really we needed to fill our own gaps in, and we needed to look beyond physiotherapy literature to do so. And those pennies dropping, it's really interesting and exciting to have heard that you had similar sorts of moments, because I think I've heard from a lot of physios that do. In these circumstances as well, patients will. Sometimes we need to bring a functional exercise forward in order to help place our more sterile exercises into their contexts. However, there is delightful moments more often than not where a patient won't come in and say, loved that exercise, I'm feeling better. They come in and say, maybe love that exercise, but they'll often say, and then I noticed that when I checked around my blind spot on my way here, it made me reflect on how much better that was than 2 weeks ago. Usually they'll put it in that Take that moment, don't then go, okay, well here's another.
Let me check your right rotation. Oh yes, you're right, you have improved.
Yeah, exactly. You could so easily see that being, oh, it's a really nice story, I'm glad you're doing better. Now let's come up with, use this biofeedback unit more specifically, embrace that, take that chance and scale it to function for that individual's life. Now, one of the best things is that this conversation has walked from that loosely diagnostic conversation, assessment conversation, through to functional rehab. But you cannot find out what to functionally rehabilitate unless you ask them good questions in the subjective assessment, elicit the narrative, find out what's going on, and you will lean on that throughout the treatment plan. I mean, I'm sorry to put words right in your mouth.
No, absolutely.
That's what I've just heard from this conversation, which is just why it's so important. And obviously we're into questions for various ways. But when I hear you explain it as you have and walked through why those questions are important, why understanding what someone challenges, knowing the age of their grandkids may be well relevant to whether they're picking them up from the floor or whether they're picking them up from college. It matters. And so we want to make sure we're thorough, and that's what it sounds like you're doing. Anything else you'd like to add before we wrap up?
No, that's fine. Thanks very much for inviting me to be on the podcast, Joe.
Absolute pleasure. We'll share any of the stuff that we've discussed, any favourites of Chris's when it comes to the literature, and we will bring that available through our newsletter as well as on our Google Drive page, which will be tweeted and Facebooked in the usual places. Would you like to give the listeners any insight as to how they can find you? Certainly, please plug the courses I know you run, which have, I think we also ran a competition.
You did. I had someone won me as a prize. That's right. Mary won.
That's right.
Won me as a prize. That's why my kids were absolutely in stitches about me being a prize for somebody. So that was up in Sheffield, wasn't it?
And the reason I mention it is because of the reviews that came from it. It's part of the reason why we knew we needed to get you on the episode. Really highly regarded course, and I've heard that from various sources, so please do point people in that direction.
The course is the neck clinical rehabilitation 2-day course. I do a 1-day course on sensory motor neck in sport as well, and I run those through Ken Joy Health Education Seminars, and I've got my blog chrisworsfold.com, and there's a lot of videos of proprioceptive testing and oculomotor testing. I just wanted to put out there, for no charge, what I'm teaching, so perhaps those who can't afford to go on courses in parts of the world have got a resource for them, and that's hand on my heart what I'm doing that for. And there's also a bit of commentary from my 30 years in physiotherapy.
Fantastic. And your Twitter handle?
At Chris Worsfold 1.
Fantastic. So make sure you check this man out for the reasons that you've seen. This is an insight into what's to come on his courses and elsewhere, and we thank you so much for your time and bringing this available freely, as you've mentioned, lots of other free resources. And certainly I hope you've enjoyed what he said, but also please do take a look at what he writes as well. Really lovely worded blogs that will definitely give you food for thought and challenge and confront you on some of your own personal biases. Certainly does me every time I read him. So thank you so much for your time.
Thanks, Jack. Absolute pleasure. Thank you.
And there we have it. That was session 47, which is crazy to say. Fast approaching the big 50 mark. Huge thanks again to Chris for that. It was just brilliant. I think he's going to speak for itself, so I want to say very little about it because it's already a long episode. But I know one that you'll have enjoyed. Please do pour your feedback in, as I'm sure we'll flow through on this one. But just a point that I want to raise, which I kind of did in the episode, but just I want to highlight it again. What a brilliant analogy it is to use the evidence as a map. Because certainly if the evidence is used in an algorithmic way, in an empirical sense as being the parameters and guidelines in which we must practice narrowly within, then I think that can be quite restrictive on what is a ever-growing literature base that compares and contrasts various different schools of thought. So to use it as a map, as a means of just helping us to understand and comprehend our current coordinates, but also where we can deviate and explore, I think is a brilliant analogy that I'm certainly going to find myself using more and more. So thanks to Chris for that one, as well as for the rest of the things that he's then shared. Please do check out the resources, especially his blog, and find him on social media. You can find us, of course, at TPM Podcast, me at Jack A. Chew, and at Chris Worsfold 1 for us on Twitter, and of course Facebook, Instagram, YouTube. You know where to find us by now. But one of the things that's happened is that iTunes, which is where many of you catch the podcast, has changed the system so that you can give ratings and reviews on the actual app, so it's even easier. Because it helps the show become more findable. I've not really described that very well, but you know what I'm meaning. And so if you can give us a review, open and honest. I reckon, I'm slightly biased, but I think it'll probably be up in the 5 stars. But in case it's not, you can, if you want, give a lower rating. But I'm speaking to you 5-star listeners. If you want to fancy giving us a rating, then please do. That would be really handy. I haven't shilled for that for a while. And talking of shilling, and Patreon is available, and we've got lots of other spare content going around on Facebook and on Patreon. So please, thank you so much to those that support us and keep this free. It is incredible. So you've got some brilliant episodes coming up. The final podcast of the year coming next, and then exciting announcements on the next podcast for what we've got coming in 2018. So you got that to look forward to. Do check out before, during, and after the 9th of November. Check out #TheBigRs. That's RS. To get a bit of insight into some of the stirring we're doing in person at an event in Birmingham on the 9th of November. So check that out. But until next time, you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.